Good morning, everybody. I'm David Wilger. I'm the professor in the Department of Psychiatry, and I am the Executive Director of Education Technology at UHN and the Academic Director of CPD at U of T. And it's my great privilege to introduce Dr. Ivan Silver this morning. Ivan needs no introduction to this group. And for those of you who have looked at his CV, it's exactly what you would expect, a journey that sets out many different fields and full of surprises too. You never know what's going to pop up and what Ivan has worked on. And this is my experience working with Ivan. It's full of surprises. So I tried to think about how to best to present Ivan, and I'm going to do this quickly through a personal reflection, and I call it Yiddish for Ivan and other mentors. And for those of you who have worked with Ivan, you know that you will learn Yiddish whether or not you like it if you work with Ivan. And the other thing is you don't actually know whether or not you've learned Yiddish or just made up words that Ivan has brought forward. So this is, I will walk you quickly through an experience of being mentored by Ivan as I see it. So everything starts with a Klopstikel. You come into Ivan's office in his space and he diagnoses you as being in this state, a big mess, something that needs to be fixed. And by the way, I think, Ivan, you made up Klopstikel. It's not actually a Yiddish word, but it's one of my favorite words now. And so he presents you with a worldview that looks something like this. So what next? Well, what happens next is a diagnosis. You get put into two areas. Either you're an oy vey, oh, that's bad, or oy gewalt, this is going to require some serious interventions. You're then bifurcated into a little bit of kvetching or whining and complaining about the current state, or you quickly get into Meshuggah situation where you talk about really something that's extraordinary. I put a pastrami sandwich here because Ivan and I once had the opportunity to go to the Carnegie Deli in New York and ate a massive sandwich together. He did try to order the matzo ball soup as well, but the waiter told him that that was too much and he was not allowed to have matzo ball soup, which I think was the first time anybody had ever told Ivan he couldn't have anything, have something. So he didn't get the matzo ball soup, and he afterwards said it was a good idea because it was a big thing that he had taken on. And then what happens is Ivan instills you with chutzpah. Somehow, I don't know how it happens, but he gives you a big idea and gives you the courage to make that happen. And I've never jumped out of a plane, but I'm sure if anybody could convince me, it would be Ivan. And then I think an important part of mentorship is if you're with Ivan, there's no shortage of cavelling. He really takes pride in the people that he mentors. He shares his love with everybody and really encourages and mentors in a fantastic way. And there's never any shortage of Mazel Tov, and I know I've switched languages here a little bit, but with Ivan, you're never quite sure where you are, so it's okay. And then if you know anything about Ivan, you know that he is the consummate family person, and this concept of Zaidi, I think, really crystallizes for me what Ivan stands for in really big heart, family first, and making sure that mentorship is a compassionate experience. So it's my privilege and honor to have Ivan present today and to introduce Ivan. He's been an important mentor for me, and I'm sure many of you. And so Ivan, over to you.
Thank you, David. I'm not sure I can recover from that introduction. Just in terms of kicking off on the word cavelling, I'm very proud of all of you, all the organizers of this event. I remember leading CPD in the Department of Psychiatry. It was one of my first leadership roles, was one of my most fun roles, but to see how the complexity of topics and also the number of people who are involved and young people in CPD, which I never saw in my day, organizing within the department. That's just so wonderful to see, and to see how this has been developed. So looking at the other topics for today, I think what I'm going to be doing is quite different, and maybe sets a tone with an emphasis on process, on team processes, which I think if you keep in mind, I think the other more focused areas I think will be even more functional and effective. So I don't have conflicts of interest that I'm aware of with the content of this presentation. And I want to start with some definitions, and you'll notice I'm not actually talking about team learning here. I'm actually going to be talking at first about team functioning, because this will be one of my takeaway teaching points that I'll make just a little later. But just for some definitions, we know what interprofessional collaboration looks like among a single profession. Multi-professional is something different, working alongside one another, and interprofessional is actually working synergistically with each other. Easy to say, hard to do it really well. And a collaborative practice definition by Wayne Jones, and it's so interesting that much of the best literature in this field is Canadian. So take a look at this definition. It emphasizes communication and decision making, the interprofessional process, enabling separate and shared knowledge and skills of healthcare providers to synergistically influence patient outcomes. So each and every one of those words was chosen very carefully to connote the interrelation between individual knowledge and collective knowledge, and how that can, when it's optimal, and where equity is a huge factor, then a more effective client and patient care can occur. So this is one of the premises of my talk. For optimal continuing interprofessional education or team education, you need effective interprofessional collaboration. And this was actually the basis of how the fields developed as well, when monies became available through Health Canada to foster interprofessional collaboration around 2005. The first projects that were funded in Canada were to enhance interprofessional collaboration before team education. And if you think about it, it makes sense. How can you have effective team education without effective teams? So this is really one of my main teaching points for today. So there is a synergistic and interdependent relationship between interprofessional education, either before you get your license or afterwards too in practice, and between collaborative practice post-licensure, and they are really interdependent. So you need to train health professionals to practice collaboratively, and you need teaching settings with health professionals that practice collaboratively to be able to teach about IPE, or to actually have effective team education. So it is all about the culture, I think, of cultivating interprofessionality. And if you have an effective culture, I think that teaching and learning is not that complicated. It really derives, but the work of making equitable teams and functional teams is hard work. I can tell you it's hard work. If you think it's not, I think there's naivety there, because it takes constant, tenacious attention to the dynamics of a team in order to have a robust team learning culture and environment. And just to, this may be obvious in terms of going into further detail about what interprofessional collaboration is, but I think it bears repeating. I think this is an interesting picture that I found on the internet, just because of what it says about nonverbal communication. So, you know, it's hard not to be a psychiatrist here. So you see people have a very different use of their hands. Some are crossed, some are open, some are folded. These may be significant or insignificant messages. Lots of people are smiling, and something either funny was said or amusing or something that people agreed with. People seem to be looking at one person. So I think why I'm drawing your attention to this is that the dynamics of communication and collaboration are incredibly important to be paying attention to and to be debriefed at particular times. So to be a good collaborator, there are these characteristics that have been described with knowledge, skills, and attitudes. Just take a look at these. And others and complementary characteristics could be responsibility that each individual has related to the function of a team. So not only your individual responsibility to be an effective psychiatrist or other health professional, but a responsibility for the team itself, accountability to the team as well. Being willing to be a part of a dynamic where activities are coordinated, perhaps not always in your control, not easy for everyone, where excellent communication occurs and where there is attention to the constant checking in of how you're doing related to communication on a team. Where I love this slide, very current, I guess, but where cooperation and respect obviously are needed. This is an interesting one where individuals are empowered and enabled, no matter who they are and what role they have on the team, to be assertive, and where that's respected. Again, this goes along with individual autonomy too, that is permitted and extolled and empowered within teams. And where there's mutual trust between individuals, which is incredibly important. I can't say enough about this. Again, easy to say, and maybe harder to do at all times. And we sometimes don't always realize when we're not being respectful. So Barr wrote, one of the earliest writers about interprofessionality, to be a competent practitioner, that we need to have some particular types of competencies. Individual competencies, so we have to be really good at what we're doing. We have to have competencies in being able to collaborate, and we have to have common competencies that overlap, like transprofessionality, where we all share certain competencies, knowledge, and skills, and particularly our knowledge about how to be effective together. So another way of looking at this through another lens is to be a collaborator. You need to be competent in your own professional role. You have to have competence in the collaborator role within one's profession, so your interprofessionality, and you have to be competent in the collaborator role with others. And this framework was really clearly defined by Lorelei Lingard, who wrote about collective competencies that exist on effective teams. And I invite you to, for further reading, this is one of the most clearly written articles and highly cited in the entire IPE or CIPE literature. So I think I made this point already, that this is actually complex, the interprofessional, interdisciplinary work in our settings, as if you don't already know this, because I know anyone functioning on a team where there's inpatient, outpatient, medical psychiatry knows what this means, and it requires constant attention to process. So I'm going to talk a little bit about an elephant in the room, and it shouldn't be an elephant at all. We need a much smaller animal than this in terms of our future. But the elephant in the room around effective team functions is this: power and hierarchy and power and conflict. So Elise Paradis and Cynthia Whitehead wrote a lovely paper on power, conflict, and hierarchy in the IPE literature. Reviewing the literature prior to this of all articles on IPE, and they found over 2,000 articles in the previous 10 or 15 years, and only 6 of these articles made any reference to the discussion of power. And they stated that if the literature ignores this reality about how powerful these issues actually play and the power they play on effective teams, how do we expect team education, IPE, to become an education model that will lead our students in the health professions to collaborate or encourage us as faculty and staff to collaborate? They stated that by ignoring power and conflict, the literature is actually obscuring what it is that IPE initiatives are theoretically aiming to correct. And so for team educators, for us to really change the healthcare system, power and conflict must be continually addressed by teams. So Witz was a theorist who wrote even earlier than this about how teams work, and devised a concept called professional closure. So there are strategies used by different groups to exert power. We may be more familiar with our own strategies as physicians. And it's so interesting. This article is very interesting. The framework is very interesting, but even more interesting that colleagues of ours, Lindsay Baker and Tina Martinakis, about 9 years ago, did a study of some of the IPE research and programs that had been funded by Health Canada and the Ontario Ministry of Health, and did a multi-center study interviewing based on interviews of people's concepts of power hierarchy within interprofessional teams. And this was actually one of the 6 articles that was that had been previously noticed by Elise Paradis as being an excellent example of a IPE study that was concentrating on power. And so she, using Witz's model, described one phenomenon I think that bears repeating. That team education itself, or interprofessional education actually, was seen by many non-physician groups as an opportunity to assume more power within a team. The opposite was true among the physicians that were interviewed, where they felt the power was being threatened. So there is there were many other interesting findings too, and using Witz's model, there was increased complexity in that analysis, but that was one of the main takeaway points from Baker's paper, something to really think about when doing team education. And an interesting paper that talked about the language that we use in everyday care sends messages that can consciously or not undermine the explicit lessons that we're actually trying to teach. So again, this was a great title for an article, 7 Dirty Words That Undermine Interprofessional Collaboration. So they defined these 7 words, which you can see in this little table. and then there are cleaner alternatives. So take a look at the alternatives. So I don't see, this was written 4 years ago. I have not heard anyone describing a clinical setting as an experiential placement. Um, but this attention to language is very important. There was a time when I felt, my observation was that interprofessional terminology was actually more prevalent than it is today. So I felt around 2005, 2010, more people were dropping the term allied health professional or interdisciplinary and substituting interprofessional. I've actually seen lately a swing back of terminology back to traditional words like interdisciplinary, like allied health. And I think it just points out the importance of culture, our dominant culture as physicians, and how, again, if we really want to change things, we really want to encourage participation, we really have to pay attention to this. So take a look at these cleaner alternative expressions and think about your own use of them. So I also want you to reflect on how power and hierarchy impact on your daily work and the work of others. So what are you doing day to day that's impacting on the attitudes or the work of other health professionals? And it's just something you can think about for a few seconds, and to think about it perhaps in the Q&A as well. So what is IPE? We've talked about effective collaboration, and the World Health Organization defines this as an opportunity for learners from 2 or more professions to learn from, with, and about each other to improve collaboration and the quality of care, which is one of the themes of this day. So CIPE, which is a newer field, I adapted this definition. You notice there's one extra word here. So it occurs when participants from 2 or more professions learn about, from, with, and here's the word, for. So that's missing from the IPE definition of the WHO. And this was not my idea. About 5 years ago, when I was overseeing interprofessional education and collaboration strategies for the Department of Psychiatry as a part of the STRAT plan before this one, Edward Flack from the Mount Sinai, when we were looking at definitions, came up with this, and it kind of stopped us cold. So we thought, oh my goodness, this is such an important word. What is our responsibility in our learning in teams to make sure the learning is shared, that actually it's a higher calling about team learning, that we'd actually be learning for the other members of the team as well. So I just think it's such a powerful word. It needs to be added, and let's add it for CIPE. And there's 2 ways to think of IPE, and I really like this typology, that it's actually a way of improving skills, knowledge, and behavior change through, say, something like quality improvement or patient safety interventions, so that something objective is learned. But it's actually a pedagogical process too. It's a transfer of values about the value of the process that we're using to do the teaching. And I think we're going to do effective team education if we can move nimbly between these 2 frameworks. We'll get it right if we're doing it well, we're teaching well, but we're also paying attention to the values inherent in our communication. And these are defined as IPE competencies, Canadian national definition. So role clarification, the quality of communication, the patient family, community-centered care, team functioning, collaborative leadership is an interesting one, Here's conflict resolution. I'm so glad that made it, and team learning and teaching. So these are the things that we can aspire to around being effective team teachers. There's good evidence now that IPE actually has an impact on quality of care. We're not there yet, but in the latest BME review, Best Evidence in Medical Education by Scott Reeves in 2017. He found at that time the 46 high quality IPE studies, and these were the results. So they're at fairly low level. Learners like it, and that includes CIPE learners as well. Several studies were in that area. Attitudes and perceptions of one another improve. Collaborative knowledge and skills increases, but there's a more limited but growing evidence that changes in behavior, organizational practice, and benefits to patients and clients. So that's really the area we need to focus on moving forward. But it's very encouraging as this field has developed that there's growing evidence that educating in teams is effective and can affect the quality of care. So the last part of my talk is 12 things or processes that you can do to add more CIPE culture to your teaching. Okay, and they're not in any particular order. And one of them, which might not be immediately obvious, is creating a value statement about your commitment to each other on the teams that you work on and on the teams that you want to learn with, from, and about, and for. This is one example taken from the Center for Interprofessional Education. You'd think the center in Toronto would have a value statement about how they're going to work as a team, but I'm suggesting that you think about doing this on your team. So the last time I did this, I remember as a CPD Vice Dean at the Faculty of Medicine, we had such a statement. We had it in all our meeting rooms. It took us months and months to come up with it because the process of devising what should go on that list, what was really inherently important, needed to be articulated. So it's hard work to come up with something like this, but it was worth it because we had a frame to keep referring to when things weren't going very well. So something, again, maybe off to the side, but I think is a foundation for effective team teaching. So it goes without saying we want to use best practices in curriculum planning. This isn't altogether that different from the best practices that you would use in devising your CPD interventions. From having an interprofessional planning committee that really represents the group that you're involved with in teaching, that you're doing needs assessments, scans, you're designing the activities again interprofessionally, you're evaluating, and you're actually conducting scholarship too. So. And you're going to hear much more about this one, but I think this is really a rapidly developing field that you can do really effective team learning with a very specific focus like quality improvement and safety lens. I think it really helps to have a frame like this, a goal like quality improvement, safety, better patient care. No one is going to argue with that. That's what we're here for. That's our mission. That's our job. And it's a rallying point around effective teams. But at the same time, I hope I've made the point that you can't do this well either if you have a dysfunctional team, or even if you have a team that's less than optimal. So paying attention to team process may and probably will help your ability to do effective quality improvement that's team oriented. And not to forget, where is the patient on the team? And so how do you conceptualize the patient's role? Angela Toll from University of British Columbia, another paper that I would suggest you read, outlined about 6 levels of patient involvement in education that we should all consider. And the highest level is to have patients as teachers, patients as facilitators, patients as co-planners of curriculum. This would necessarily be all curriculum, but where is the patient on your planning committee? And which patients would you choose? These aren't easy things to think about, but having some hard thinking about the role of patients beyond their usual role of being interviewed or storytellers about their patient experience, which there's nothing wrong with that, because that's we need patients for teaching, but to elevate patients as having a higher role and special knowledge about their illness experience, about the healthcare system, about how to improve the healthcare system. I would maintain that having patients as a part of team learning, for much of team learning, can be very effective and can add a whole frame of reference you wouldn't think about otherwise. We can't speak for patients. Patients need to speak for themselves. I would suggest that you build as much team learning into the interactions you already have. So when you're doing patient case conferences, when you're having rounds, which are interprofessional, you have an opportunity to do some teaching as well. It doesn't, that becomes a part of the structure of those rounds. So time is precious, and it's hard to rally people together for a special team learning event, no matter what the topic. But if you're integrating it into what you're already doing, but changing slightly the focus so that there's some team learning, I think this is efficient and better received. We're doing some new interprofessional collaborative processes in the interest of patient safety and quality. One of the big ones is the huddle. The huddle culture, 5 years ago kind of swept the GTA. We were all doing training of our teams with clinical huddles. They seem now on many wards and units, not so much outpatients, but inpatients. The huddle has become kind of a piece of the structure, and this is a wonderful development. But huddles are also opportunities for teaching and learning. Briefing and debriefing critical incident events that occur are often interprofessional events and opportunities for team learning. So this is what clinical huddles look like now. I know at CAMH this has become on inpatient wards kind of routine function. You wonder too how long that's going to last, because again it needs constant attention, constant leadership to continue it as well. So briefing and debriefing also opportunities for interprofessional interaction, but also to bring in specific teaching moments and teaching points. This is an interesting exercise that's done right at the beginning of the Educating Health Professionals and Interprofessional Collaboration course that's held every June out of the Center for IPE. I was one of the original faculty and taught at the course for more than 10 years. But having teams sit around and just doing this interesting exercise is what do you think you have in common with each other? If you have 6 different health professionals sitting around a table, and what do you think that you bring to the table professionally that is unique? And it's very interesting what people put in those circles that could surprise you, but what it does is it fosters really interesting discussion, and it's kind of a trigger or an icebreaker for an hour on team functioning that your team could do. Making sure that you engage representatives of the relative health disciplines to plan your teaching activities or the teachable moments. So do you have an interprofessional education group on the team that you function? It could be 2 or 3 people representing 2 or 3 disciplines. And again, physicians cannot plan effective activities that are going to involve a team or where you expect teams to other members of health professions to participate unless they have also participated in the planning and leadership. And for group learning, ensure that the learners from each health discipline can see their discipline's issues in the curriculum. And this is not easy to do. I can tell you, it is not easy to do. And you're not going to get it right. It's almost like asymptotic curves, if you remember your geometry, of these curved lines that never reach the perpendicular. But we can try. And we can try and be more effective if we're having opportunities to have dialogue with our teams about how the team is doing. So making sure you also build IPE competencies, that those are reviewed as well as a part of your curriculum. And the curriculum really are your practices, the everyday work that you're doing. You don't have to go far beyond that to see what's important. And it can be based on the kinds of events that are occurring on your unit, what isn't going well, where the team actually, from a functional point of view, isn't as effective. So paying attention to your capacity to collaborate, to provide effective quality care, and the education can actually be partly based on improving team practices among the team. This is, I added this because I think the curriculum that we should be teaching our residents in some ways has gone missing. There is Royal College expectations, but this was some of the work that we did about 5-6 years ago with the previous STRAP plan that looked at what a curriculum for residents might look like. And I'll just have you look at that for just a few seconds. And so it consisted of a variety of things that, again, were based on the Royal College expectations in competency-based education, but also included some other activities of facilitating, leading, conducting a team assessment, and an interprofessional QI project as well. So again, I think this needs to be better formulated in terms of what we're doing within our own Department of Psychiatry. And this is another area that doesn't get much attention. So how are we training the next set of leaders in team learning? So this could center around our initiatives in quality and safety, but I think it's more than that as well. So who on the unit is in charge of team learning? And how do these people actually get together? And what kind of leadership training might enable someone who's not a physician actually to be leading this, but to make it authentic so they really have leadership authority and not just in name only. But it's an area I don't think, I've included this because I thought this would be interesting to explore, but not developed yet. And team assessment, I think, is something we need to pay attention to. Just to draw your attention to that there are tools to use if you want to do further reading. The first one is the American Board of Internal Medicine. There's the STEPS Teamwork Perceptions Questionnaire. And so it might mean every 6 months or once a year, the team fills out an assessment tool. It's anonymous, it's collated, and then the results are discussed at a team meeting. Or you can do this having an external person come in and do interviews with your team and then feed that back. I think it's that important if you're going to have effective team education. And there's lots of resources. I give another website related to interprofessional practices, lots of instruments available around self-assessment and advancing interprofessional practice. So the very last part is this is supposed to be fun. So David Wilger mentioned, I like to surprise. So it's nice for me to remember a period of my career when we used frame games. And so I became very interested in this earlier in my career. A frame game is a game that you make up a set of rules, but then, and all kinds of materials too, but you can download any content. And I devised a frame game called Stir Fry to improve interprofessional collaboration or to enhance it, and mainly as a retreat activity for a team. And I had an artist draw up this. I presented this at conferences and got to travel across Canada, where I would bring my materials, but I would work with a team in another city who would devise all of the questions that we would be focusing on, all of the content, the curriculum. They would do that on their end, and then I would download it into the frame of the game. This was before computers. This was face-to-face, and I'll show you what it looked like. So that's me on the left, much younger. I had a beard then. This was a team I went to in Ottawa. It was actually a community hospital-based team in psychiatry at the Royal Ottawa Hospital. I had 4 teams like this. I call what you're looking at that they're doing as hyper study because it caused intense activity to answer questions. So it had a Jeopardy kind of theme where there were questions to answer, but they weren't just facts. They were problems. They were cases. You could download quality and patient safety issues. There were role plays. There were time trials. There were lots of different activities to keep it fresh. And this went on with a break, a couple of breaks for 3 hours. So it was really meant as a team functioning. And at the end of it, there was a debriefing as well. I had a game board, I rolled up in a scroll. Those are little Velcro, those little white things are Velcro. And then I had styrofoam balls that they attached to. Each one stood for a team. The colors stood for categories of questions. The frequency of the colors depended on what I felt. There was always something more important in the curriculum they had, so the colors showed up more often and they landed on it more often. Look over to the right. You see dice on the table there that people rolled. They're large dice. They were kind of made of felt. That's me. I was the games person. We usually had the leaders of the team play the kind of the gopher roles. The person standing there was the head of that, medical head of that team. The people sitting at the table were judges. They wore robes. Some wore other things, like when we did this game at Sunnybrook when I worked there. This is another picture. Look at the overhead projector. That just sort of puts that in time. But this was when I played it for the first time intra-professionally. There are some people there you might recognize. The person wearing the mop is Dr. Bob Yonkons, who's a medical psychiatrist at Sunnybrook. The fellow in the middle is Ron Billings, who's retired. That's Steve Sokoloff. Some of you may know him from CAMH in mood and anxiety and leadership roles. And that's Carol Cohen standing up. And we played this with medical students when we had clinics for third-year medical students in the olden days, and we had them for a long time. We used the game to review the curriculum before their exams. So I think a number of references as well, but having fun is effective as well, and it's a celebration too of what you can accomplish as teams together, both for care and for learning. And I think I'll stop there.
Ivan, thank you for that wonderful talk. I've seen you speak many times, but every time I learn something new, and it's so engaging. I know you're doing this virtually. The other talks I saw you doing it live, which is an experience in itself. But you did an amazing job. I was engaged throughout the presentation. And thank you for highlighting this very important area that I think, all organizations to actually give the greater emphasis. There is some emphasis, but giving the greater emphasis and the importance. And I was busily writing down a lot of questions. I'm going to ask the audience as well. I know there's, if you have questions, please put it on the Q&A. And I think we have some time so we can talk about some of these questions. So one of the first questions that I thought about, because you were talking about interprofessional learning in various settings, and You talked about the community setting and then some academic settings. I was wondering, is there different challenges or different things that we have to think about in the two different settings from your experience?
Yeah. Well, no, I think the principles are the same. So it's really attention to process. So who are you engaging? How have they been involved in the planning? What are already the connections to the people that are going to be involved in the learning? How can you engage the people that are going to be gathering for the event or activity if they come from two different worlds? Maybe they're a community team that connects to a hospital team. From a process point of view, when I would have gotten that kind of group together, I would be doing quite a few icebreakers, again, for people to get to know each other before the learning. Well, that's part of the learning too. It's still learning about collaboration, communication, and being comfortable in your spaces and respectful too of the different perspectives that the two groups are bringing. So I think really paying attention to process creatively.
The other part that I noted down was very interesting. You talked about the dirty words that slide on that, and I was intrigued by the fact that you're right. This the allied health, for example, it's sort of coming back in vogue and sort of talking about, but hearing you talk about it, I mean, it sort of gives a different type of tone when you label clinicians or colleagues in that type of language. I mean, why do you think it's coming back, and what could we do to maybe change the trajectory on that?
Yeah, so I mean, I think it's a very interesting dynamic issue. I noticed at my own hospital that the dominance of physicians compared to the other health professions is really quite profound now. And I've only been at CAMH for 11 years, so the last time I was there was when I was a resident. I always found the physician dominance to be, quite apparent. But I think in the time I've been at CAMH, it's even grown further. And it's the predominant prevailing culture. I don't think necessarily it's different in other hospitals, but if we want to change things, it just implies that it's hard work. So knowing that there's a dominant physician culture, I think there's a reality to that. So how are we going to cope with that? And I think bringing our colleagues or other health professional colleagues into it and talking about what matters, what will make a difference, what will help others to feel included, bringing in patients as well, who are often left out as well, and who we can really learn from, are some of the ways. So, I've had interesting conversations with nurses and social workers. When I talk about the 7 dirty words, they say, that doesn't matter. And, in a sense, there's a hierarchy of priorities too. So words are important, and I just point them out because I think it's interesting. That's not probably the most important dynamic. Power is, and how, that's shared. And for physicians, I think we have some responsibility to do that, to make efforts. So when we're doing our safety and quality improvement activities and exercises, that we bring in the other health professionals that are relevant. We empower them, to lead and to be present.
That's a great answer. I mean, there's a question on a Q&A from John Tashima, I think follows in the same line about the power dynamic. How can physicians encourage based learning without inadvertently reinforcing the historical, hierarchical roles? But I think you answered that to some degree. But I'll let you come back to a different answer. The other question that was asked earlier on was sometimes working with colleagues, even managers, that may not be clinical based, not necessarily, I think what they were trying to get at it, not necessarily solutions per se, in administrative roles, and how do we kind of change the culture when the majority of decisions are made in that type of setting, where maybe managers or some administrators may not have clinical competency but do make a lot of the decisions. So how do we encourage collaboration?
Yeah, so again, not a simple answer. We have structures within our hospital and intradisciplinary reporting structures that physicians don't have any rollover. So these are attempts by they're phenomena of professions to demarcate their territory and their position, and all the power to them. That's what they should do. But there comes a time when we need to sit down together, and I think it is about process, it is about conversation, it is about opening this up to having difficult conversations that need to be facilitated. So the facilitation of this needs to be done with the leaders need to be skillful at dealing with power and conflict. That's why it's been avoided in the literature, because it's not easy. It's not easy with our patients, right? When we're dealing with people who are in conflict with you, and it's not easy to deal with in our teams. And I think the answer is, skillful facilitation, and particular attention to ongoing, tenacious attention to the importance of checking in with our team on how we're doing. It's as simple as a debriefing a meeting. What have we done today that we want to continue? What have we done today that we want to stop? It's fairly simple, and these kinds of things become a part of a team conversation. The people are expecting the last 5 minutes is going to be in a team meeting is going to be dealing with how the team did in accomplishing the goals for the hour. And I think those kinds of things, that kind of attention, helps build facilitate a collaborative culture, and it's simple and I think necessary. Can't hear you.
There was another question about your perspective on creating virtual environments that are engaging for IPE training. With your experience, what do you any thoughts on that question?
Yeah, that's such an interesting one. So that's the next research area for one of you. It's probably going to be more than one of you who are sitting there listening to this. So, because I don't think much has been done in terms of studying it. We're all trying to do it now, trying to figure out, but this is the next generation. I had such an interesting experience about 6 weeks ago. I was an avatar. I was an avatar at the medical education meeting in Europe, and I was teaching a master class with Yvonne Steinert, and I was not me. I was looking at me teaching, but what I saw before me, first of all, I needed 2 hours to debrief that experience. It was so weird. But I could see the future. I could see the future of effective teaching and learning, where we might become avatars. We go into a virtual environment. We can interact. I had hallway conversation with people after. I couldn't see them. They were all dressed up in somebody else's clothes, like the avatar they had created, but I recognized their voices, and I could see the potential for breakout rooms, for interacting in a group as though I was there. But it's so early. So I invite, I know there's some interesting work going on at Sunnybrook on virtual environment and teaching. And so I just invite you to play with this. This is the next field. This is for one of you to take forward.
Thank you, Ivan. You spoke about some other aspects that was very intriguing as well. Talked a little bit about surveys and the importance of anonymous surveys and how that can help facilitate building teams. And talk a little bit about that and your experience.
Yeah. Yeah. So it's like in some ways like the same impact as any kind of feedback or 360 review. In this case, it's a self-assessment and of a team. So this can be done through filling out each person's perceptions of how the team is doing, and then collated anonymously, and then shared among team members with a plan of action to decide what maybe needs to be different, or to begin the planning of that, and again through team function. So we do have the tools now for doing that, and just invite people to explore that further. There's also some credibility in having an external person come in to observe your team, to be like fly on the wall, and to be giving feedback in that way. And it will really depend on how your team works and what fits your culture as to what might be helpful to continue to improve. So it's quality improvement. It's quality improvement of your team.
Thank you, Ivan. I could keep going. I mean, I wanted to ask some questions about patients, and you talked about bringing allied health into curriculum, but I'll follow that up on a personal level. I know we can reach out to you at any time. Thank you for this wonderful presentation, and I really appreciate you making the time. I know how busy you are with so many things, but I think it was really great for our learners and the QI community, as well as the CPPD community. Thank you again for making the time.
Thank you for inviting me.
You're welcome.